Good morning. Good morning, everybody. Good morning, Deb. Good morning, Ellie.
Morning.
I'm standing in, Deb, for Rob Beanlands, who's at the division chiefs meeting this morning, but Ellie does all the talking and all the work. I'm still in my pajamas.
Good morning, everyone. Welcome to Cardiology Weekly Rounds. It's my pleasure to welcome Dr. Deborah Siegal this morning as our guest presenter. She is an associate professor in the Department of Medicine within the Division of Hematology at the University of Ottawa. She graduated from Queen's University School of Medicine in 2009 and completed her internal medicine and hematology training at McMaster. She also holds a Master's of Science degree in both pharmacology and health research methodology. Her primary research interests include improving patient outcomes after anticoagulated bleeding, management of anticoagulants in patients who have acute bleeding complications, understanding the factors that influence patient and physician decision-making after anticoagulant-related bleeding, and reducing red blood cell transfusion by minimizing iatrogenic blood loss for laboratory testing. She has expertise in the design and conduct of pragmatic cluster randomized trials, individual patient randomized trials, mixed method studies, observational studies, and meta-analysis. And she's received multiple grants from CIHR, American Society of Hematology, Heart and Stroke Foundation of Canada, Ontario AFP Innovation Fund, and the Hamilton Health Sciences Foundation. She's published 80 peer-reviewed articles, several of which in high-impact journals such as the New England Journal of Medicine, Circulation Blood, and the Journal of Thrombosis and Hemostasis. So we welcome her this morning, and she's going to give us a presentation on DOAC-associated bleeding. So we look forward to your presentation, Dr. Siegal.
Thank you so much. And also, hopefully you can hear me. Thank you so much for the opportunity to present. It's really an honor. I was just reflecting as you were speaking that I've been here for 7 months, and I'm considering how nice it will be when I can meet people in person. But really glad to be here. So thank you for the opportunity. I'm going to talk today about DOAC-associated bleeding, which is my area of interest. And you may be wondering what this beautiful mountain range here on the slide is for. And it's something that I've started incorporating into my slides kind of peri-COVID. And this is the Dawn Wall, which was mountain in Yosemite National Park, and it was considered, unclimbable. And it just sort of put it here to remind me that, often the work that we do seems totally unachievable. But there were 2 climbers that actually achieved this climb using that pathway there after many years of hard work. And so it's kind of an inspiring story. And if people are looking for something to watch, it's a great documentary. So on we go. I do have some disclosures. I've received honoraria for attending advisory board meetings for some of the manufacturers of anticoagulants. I'm hoping that at the end of this session that we will have reviewed the general principles in managing DOAC-associated bleeding and discuss the role of reversal and hemostatic strategies. And I'm happy to take questions at the end. That would be, it's a good opportunity to discuss. So I wanted to frame our discussion today with some key messages here. And this is really, many of you, all of you use anticoagulants or look after patients who are on anticoagulants. And just to remember that we often get asked about anticoagulant reversal, but in reality, reversal is just one part of the bleed management spectrum. And in fact, prevention of bleeding is the first step of bleed management. And I think there's a lot more that we can do with respect to prevention. Once a patient has had a bleeding complication, it's important in the acute setting to use protocols that have early supportive measures and interventions, procedural interventions, for example, to stop the bleeding. Anticoagulant reversal is really indicated for severe or life-threatening bleeds. There are also hemostatic strategies, and I'm going to distinguish between the 2 in upcoming slides. And then finally, this is my most recent area of interest research-wise is that reassessment of anticoagulants after hemostasis is achieved is really important. And there's a lot of uncertainty about that, but even reassessing itself is really helpful. I don't need to really emphasize this to this audience, but it's always good to just kind of go back to the beginning and understand the sort of burden of this problem. Anticoagulants prevent and treat cardiovascular diseases. And we see a lot in the thrombosis clinic, and on the wards we see a lot of venous thromboembolism. But of course, the most common diseases are things that you deal with: coronary artery disease and also ischemic stroke. And really these remain a leading cause of death and disability worldwide, which is why we're all here. That's close to 18 million deaths from more recent data. And then just to kind of give a sense, in North America, over 40 million prescriptions for oral anticoagulants are given annually. This number is old, it's probably higher than that now, and it will continue to grow going forward. And so this is where, I come in as the hematologist giving cardiology rounds. Bleeding is the major complication of anticoagulation, and patients will often ask you, doctor, what is the side effect of, apixaban? And it's really, that bleeding is the major anticoagulant complication. And even with the DOACs, patients still experience a risk of major bleeding of about 2 to 4% per year. And of those bleeds, GI bleeding is the single most common site, accounting for up to 50%. My interest in research, and I'll talk about that in some later slides, is around GI bleeding. I think it's often perhaps under-recognized or underappreciated as a major source of morbidity and mortality. So I'd like to emphasize that really the majority of bleeds that we see are GI in nature. And of course, we're fortunate that the DOACs were introduced, and these are associated with reduced risks of major bleeding and intracranial bleeding compared to warfarin. But also remember that on the whole as a class, there is an increased risk of GI bleeding with the DOACs compared to warfarin. So this is a slide which identifies from the large phase 3 clinical trials in atrial fibrillation that compared DOACs to warfarin, the case fatality rates for major bleeding. And you can see those. These are patients who presented with major bleeds and their risk of dying with short-term mortality. And you can see that overall, the rates are higher with warfarin and DOAC. Of course, this isn't a meta-analysis, so we're just using this to illustrate a point here, but and that might reflect the fact that there's a higher incidence of intracranial hemorrhage with warfarin, and so the mortality rates are higher. But overall, even with the DOACs, you're seeing mortality rates here of 7 to 10%. And one of the things I wanted to identify on this slide is that even in the reversal studies, which we've seen, and I'll talk about later, ANNEXA-4 and REVERSE-AD, the 30-day mortality rates in those studies in patients who received anticoagulant reversal were 11 to 14% at 30 days. So just to say that, major bleeding is a big problem for our patients who experience it. But there are other consequences of bleeding. Often we see that anticoagulants are withheld due to concerns about bleeding risk. And sometimes this is, patients who are perhaps older and frail or multimorbid. Anticoagulants are often permanently discontinued after bleeding, and not just intracranial hemorrhage, but GI bleeding as well. And then finally, we see this very frequent off-label use of the low doses of the DOACs with limited data about safety and efficacy for those doses. And so in reality, over the next 50 years, I had alluded to this before, the number of eligible patients who are going to be receiving anticoagulants is, going to be twofold higher. And so bleeding is really a growing health problem. And so strategies to reduce the incidence of bleeding and also the morbidity from bleeding are really important. And so I put this slide up just to remind folks, and I do this actually in my own practice, there is a spectrum of care. And so, managing a patient on an anticoagulant involves initiating the drug, obviously. And then there's, routine follow-up that goes along with that. And that obviously depends on the clinical context. And then finally, management of complications. But really, this is like an iterative process as opposed to discrete episodes in time. And so, again, we start with bleed management starts with prevention. And so this is, a slide that just summarizes some of these key points, which I'm sure everybody is aware of, but it's just to help remind that, understanding or reviewing the indication and making sure that a patient does have an indication. I can tell you that in the thrombosis clinic, we sometimes see patients, often it's in the perioperative setting, where we wonder why the patient is receiving an anticoagulant. And so we do have an opportunity to discontinue anticoagulants sometimes. It's important to do baseline blood testing, and I usually do, a hemoglobin and a platelet count, liver and renal testing at baseline in addition to coags. And co-medications are really, really important. We see time and again that often patients are on, medications that have pharmacokinetic or pharmacodynamic interactions. And so it's just important to have a good pharmacist on your team to make sure that medications are acknowledged. The drug and dose is really important here, and that might differ depending on the patient context, although we don't have great evidence for that, but I think it's just still helpful to remember, that the drug and the dose is correct for the person's indication, weight, renal function, etc. And there are tools, I think, in the atrial fibrillation world. There are lots of tools that exist online and incorporated with EMRs to help with that. And then finally, education and counseling. I do this in the hopes that patients will recognize when there's signs of trouble and get in touch. And then finally, just making sure that routine follow-up is scheduled, that somebody is going to at some point consider, does this still make sense? Or is there something that's changed about this patient or data that we have available that makes us have a different plan? So I wanted to present a case because this is, I think familiar to folks in cardiology and certainly in the thrombosis service. This is a case of this is a fictional case, but it's a typical male patient who shows up to the emergency department with large volume hematemesis, and he's hypotensive and tachycardic. He has atrial fibrillation, and he receives rivaroxaban for that. And he's also on meloxicam PRN, as you can see on the slide. And his initial lab work shows, a significant anemia, which is much worse than his baseline. His INR is 1.4, and his creatinine is 168, which is 2 to 3 times his normal. So of course, this patient is managed with isotonic intravenous fluids. He receives a red cell transfusion and pantoprazole, and he's referred to GI for consideration of urgent endoscopy. And then the physicians that are looking after him are wondering about additional therapy, and so they call us, thrombosis. And of course, this is what, the fear or the concern is that, when a patient is bleeding and endoscopy is done, this is what you see when you look down the scope, and it's pretty dramatic. So I wanted to use that case to frame these kinds of questions about anticoagulant-related bleeding, and I find these helpful, at least for principle, and to guide, a protocolized management. How severe is the bleed? That's obviously really important. In this case, the patient is, unstable, so it's a severe bleed. But it is actually helpful conceptually to understand, what is the context of the bleed? Is it a minor bleed? And depending on your, clinical practice, you could see minor bleeds like bruising or nosebleeds. Or you could see these kinds of bleeds, intracranial hemorrhage or GI bleeding like this. It's important to ask, have supportive measures been initiated? And often on the thrombosis service, we get called about reversal before the patient has an IV or has been transfused. So it's just really, always important to go back to the basics, even though this can be very dramatic in the emergency room. We'd like to know what anticoagulant has been taken and when, and actually I was just on a call recently. It's very uncommon for us to not know exactly what has been taken, but it is helpful because of course, there are different strategies depending on whether it's warfarin or a DOAC or dabigatran or a factor Xa inhibitor. And then finally, you need to understand whether the anticoagulant is present in significant quantities. And I put significant quantities in with apostrophes there because we don't really know there's no established therapeutic range for these drugs. And we don't really know what level is associated with, significant impairment in hemostasis. So it actually makes it a bit tricky, but there are some strategies. So based on all those questions, you then ask, okay, well, is there a role for reversal? And then if so, which reversal strategy? And some of that is context dependent. So this is a slide which summarizes, just a kind of triaging here, risk stratification. Obviously on the left-hand side of the screen in green, there are some non-major bleeds, and these are actually quite common in clinical practice. We probably don't do a great job at asking people about these. I try to in the thrombosis clinic, obviously. And I think what's important about the left side of the screen is that these can kind of herald or increase your suspicion that something is coming. And so, paying attention to those bleeds can actually be really helpful. On the right-hand side of the screen, there's the life, limb, or organ-threatening bleeds, intracranial bleeds, other critical sites, pericardial, bleeds, retroperitoneal bleeds. Those can be really serious. And so obviously patients can land anywhere along this spectrum. And how you manage the bleed really depends on, the severity of the bleed. So for most non-major bleeding, anticoagulants, particularly DOACs, are often continued, right? They're really easy to stop and start. They have short half-lives. The onset is pretty quick. So it's easy to discontinue those in the event of an increasing concern about bleeding. Obviously, local measures are important. And I think here in green, I wanted to identify that it is helpful. If a patient all of a sudden is having a lot more bruising than they did before, it just makes me wonder if something else is going on. Have they started another medication? Is there some kind of organ impairment like, liver disease or something that's happening? And so just repeating those investigations, routine blood work, and reviewing their medication list. Sometimes this can be herbal products. And there are, we do know that there are some herbal products that interfere with platelet function, like, high doses of garlic or ginseng or ginkgo, and so fish oil. So I ask patients about that, and it's actually a really easy place to start, particularly if someone's having, more unusual bruising. As you kind of go on to the right-hand side in severity, obviously you're going to interrupt the anticoagulant at this point and apply general measures like, compression if that's needed, or volume replacement or transfusion. And definitive interventions are really important. At the end of the day, if there's a hole in a blood vessel, a procedure is required to stop that bleeding. Anticoagulants, as we always say, they don't make you bleed. They just make your bleeding worse. It makes it, we tell patients it takes longer for your body to stop bleeding. So you do need the help of an interventional radiologist or a gastroenterologist or surgeon sometimes. And then on the right-hand side of the screen, we're talking about now, urgent administration of reversal agents or hemostatic factors like PCC, and I'll talk more about that in a bit. We're also seeing increasing use of adjunctive therapies like antifibrinolytics. We don't really have a lot of data in this setting for the use of tranexamic acid, but it is something that we're contemplating more and more. We've had very large randomized trial data now that, there is not an associated increased risk of thrombosis in, tens of thousands of patients who've received these drugs in other settings. So we're more comfortable giving these, particularly as an adjunctive therapy in this setting, really does make sense. So the next step here really, so we've identified that the patient has a, severe life-threatening bleed. We want to know, well, is there a significant level of DOAC present? And this is tricky because, the routine coagulation tests that you see that you're familiar with listed on the left-hand side of the screen here are not accurate or reliable for detecting the levels of the DOACs. And you can see that's indicated with the, all of the ones that are not very good at detecting levels of DOACs are indicated by red X's. And you can see, so for example, for rivaroxaban, I put an orange check mark for INR and PT. That's because some assays can detect some level of rivaroxaban, but it is not very sensitive. So you are not reassured necessarily by a normal PT or INR if someone has taken rivaroxaban. Same thing for the PTT in someone who's taken dabigatran. Most assays are sensitive to some level of dabigatran, but there may be assays for which there's just low sensitivity and you're not reassured. So this can actually be really tricky. The thrombin time here with a green check mark is a super sensitive test and probably detects levels of dabigatran that are really, really low and maybe not even hemostatically important. So it actually makes it quite challenging. We do have these other tests, which are the specific DOAC assays. This is the dilute thrombin time, and that's accurate and reliable for measuring dabigatran. The eccrine clotting time, same thing. And then for the factor Xa inhibitors, we have calibrated drug-specific anti-factor Xa assays, and those are accurate and reliable as well. But all of these specialized tests are done in the coagulation lab, and we do them here in Ottawa, but it's like kind of 9 to 5 with a 4-hour turnaround time. This is not, these tests are not ideally suited for emergency situations or which are the cases that you would actually want to use these tests. So it becomes very tricky. And of course, we don't really know what the therapeutic levels of DOACs are. And so what they can be useful for, these coagulation tests like INR-PT or APTT, which we're familiar with, is they can be used qualitatively. So if the PT is prolonged, if the INR is high, if the APTT is prolonged, that suggests that there really is significant levels of drug on board. They're just not sensitive enough to rule out anticoagulant effect. And so you really need to interpret the results of the tests that you get. This means performance of local assay with drug. Most people probably don't know that. I don't know that. I'm new to Ottawa. So, that's really tricky. But what is helpful is knowing which drug the patient took when they took it. So when they took their last dose is super important, and what the dosing interval is. And you have some sense of what the drug pharmacokinetics are, like the half-life, and then what their excretion is. So let's say renal function, especially for dabigatran, if the person's in acute kidney injury, then that will increase the level of drug potentially and or duration of the half-life. So again, the specific DOAC assays are useful, but they're more reliable, but they're not routinely available. And this slide just summarizes, how, so in the absence of having really good lab testing, what do we do in this setting? Well, we use what we know about when the patient took their last dose and the half-life of the drug. And you can see here, I summarized the characteristics of the different DOACs, but really I want to call your attention to the half-life, and because I'm a simple sort of gal, they're around 12 hours for most people, 10 to 12 hours. So it's helpful to understand if a person took the drug, 3 days ago and they have normal renal function, it is unlikely that that person still has clinically significant levels of drug. If they took it 4 hours ago, well, that's actually, peak effect. And then you can kind of have a sense in your brain of, whether or not that's likely to be present for some time, depending on their, renal function and liver function potentially as well. So when do you consider reversing anticoagulant effect? Well, these are the common scenarios. Severe life-threatening bleeding, as we talked about, critical organ bleeding, obviously, intracranial hemorrhage. We've had patients actually even recently with large pericardial hemorrhage, ongoing bleeding despite measures to control bleeding. So the patient's still bleeding and you still believe that they have anticoagulant on board, that's reasonable. Again, bleeding here with an expected long delay in achieving hemostasis would be maybe a scenario where someone, took an overdose, or if they all of a sudden, require dialysis. And in fact, sometimes we have seen this with dabigatran, particularly, all of a sudden patient ends up on dialysis and they have just dabigatran lingers for a long time, or if urgent surgery is required and it can't be done safely while a patient is anticoagulated. Those are the scenarios in which you would consider reversing the anticoagulant effect. And so in order to encourage the judicious use of reversal and hemostatic therapies, these are sort of the three principles. The person has a severe bleed. We think based on, we have evidence using a blood test, or we have the clinical suspicion that there's DOAC present in significant quantities, then reversal or hemostatic therapies are warranted. And this is important because of potential consequences of these therapies. There are also cost and resource implications to them as well. This slide I put up because I'm a hematologist, and just to remind us that the direct oral anticoagulants work at the late stages of anticoagulation. Factor Xa inhibitors, obviously, they target activated factor 10, and dabigatran with thrombin, and so there's a different mechanism of action here than warfarin. And the reason I put this slide up is because it's helpful to understand, when we talk about agents like PCC, where they might be working. And these are the agents that reverse DOAC effect. So these are the only ones. And I would caution you that PCC has not reliably been shown to, quote, reverse anticoagulant effect of DOACs. And so I wanted to identify these here as Idarucizumab is a humanized monoclonal antibody fragment against dabigatran. I'm sure people are familiar with it. We have it available in Canada. Andexanet alpha is a human recombinant factor 10A variant, which does not activate coagulation, but does inhibit factor 10A inhibitors. And so these are really, Idarucizumab is indicated for patients with life-threatening or uncontrolled bleeding on dabigatran, or patients on dabigatran who require urgent surgery. Andexanet alpha is different because it's only approved for the reversal of apixaban or rivaroxaban for life-threatening or uncontrolled bleeding. We don't have Andexanet in Canada. I'm not aware that it's been submitted to Health Canada, at least last time, as of a month or so ago. So there's no real timeline for it to arrive here, unfortunately. There is a randomized control trial ongoing right now called ANNEXA-I. I can't remember if the Ottawa folks are participating, and that's for Andexanet versus usual care for factor 10A inhibitor associated intracranial hemorrhage. So we actually are anxiously awaiting the results of that. I think that will be a really important trial. So what are the data? This is a slide really just summarizes that Idarucizumab, does what it had set out to do. And in this human volunteer study, dabigatran was administered to healthy volunteer patients or subjects, and they received, actually, this is kind of a super therapeutic dose that compared to what we usually use, but regardless, they received Idarucizumab or placebo, and you can see that at increasing doses, this is the dilute thrombin time. After the administration of dabigatran, the dilute thrombin time is high. That's an accurate and reliable test for dabigatran levels. And then with increasing doses of Idarucizumab, that level is normalized back down to baseline, to placebo. And in this study, this was the REVERSE AD study. I'm going to briefly summarize it. This was the registration study for Idarucizumab, and led to its approval in the US and Canada and Europe. This was a prospective cohort study. There was no control group. In this study, dabigatran treated patients who had uncontrolled bleeding or required urgent surgery were enrolled and received Idarucizumab at the dose of 5 grams IV. That's the study dose. And you can see here on the right-hand side in red, hemostasis was achieved in 68% of patients within 24 hours. That didn't include the ICH patients because there was no protocolized CT scan. And the median time to hemostasis in non-ICH patients was 2.5 hours. Again, these, and I'd be happy to talk about this maybe if we have time in the discussion, just around the challenges of measuring hemostasis in bleeding patients is one of the things I think that we really struggle to understand. On the graphs below, you can see that the administration of Idarucizumab rapidly, like within minutes, reduced the unbound dabigatran, that's the active drug, and also corrected the coagulation tests, suggesting that the anticoagulant effect was reversed. And actually, this persisted for 24 hours. So it sort of did what it set out to do. I should mention, sorry, I'll go back for a second. I should mention here that these outcomes were determined by treating physicians. It's important to, again, in our understanding of what is hemostasis and how that's measured, it's always important to keep in mind how those were evaluated. Andexanet alpha, these are the human volunteer data that we published. ANNEXA-A and ANNEXA-R patients were healthy volunteer subjects were randomized either to receive apixaban, Andexanet alpha, or placebo after receiving apixaban or rivaroxaban. And you can see in the red line that the administration of Andexanet really dramatically decreased the anti-factor 10A activity level. That's the reliable test for anticoagulant effect. And that level was maintained throughout the duration of the infusion. So it was administered by a bolus and then a 2-hour infusion, and the dose was different depending on the drug. And so that set the stage for the ANNEXA-4 study. So this was the registration study whereby Andexanet was approved by the FDA and some places in Europe. Again, this was a prospective cohort study without control groups. This makes it, has made these studies without control groups has made it really difficult to understand like the incremental benefits of these treatments. Regardless, patients in ANNEXA-4 were those with acute major bleeding within 18 hours of apixaban, rivaroxaban, edoxaban, or enoxaparin. And they received an Andexanet bolus plus a 2-hour infusion and with the dose depending on the drug that they took and then when they took it. You can see in the red box that 82% achieved good or excellent hemostasis within 12 hours. And also that this is one example from the paper is that administration of the bolus resulted in a dramatic and rapid reduction in anti-factor Xa activity, which persisted during the infusion and then started to creep up afterwards. And this is sort of in keeping with the natural clearance of the drugs. And I can say for both of these studies, the majority of patients were elderly and treated with anticoagulants for atrial fibrillation. So this is sort of the population I think that you all would be very familiar with. But it's really important, and this gets a lot of press, to understand the adverse events and what happened after these patients had their bleed with respect to restarting anticoagulants. We've heard, a lot about the concern, particularly with the Andexanet drug, about an increased propensity for thrombosis. Obviously, this is a major concern. These patients have a prothrombotic condition at baseline. They have now come in bleeding. We've stopped their anticoagulants. We've given them a reversal agent to reestablish hemostasis. Their clotting system is quite activated now, and they're sick in hospital, immobile, acute medical illness. So of course, we're not surprised that there's thrombotic events that we see after these. In the REVERSE study, 5% of patients had a thrombotic event within 30 days, and in the ANNEXA-4 study, it was 10%. It's difficult to compare these two groups, obviously, head to head, because the populations were quite different. But you can, this is sort of within the realm of what we see even pre-DOACs, like in the warfarin data, we see rates of around 5 to 10% thrombotic events. What I think is really striking from these studies is what I've identified here, which is that the short-term mortality is super high. This 13 and 14% of patients who showed up with these bleeds and were treated with reversal strategies died. And that I should mention that we don't really know what the cause of death was, but we do know that about half were cardiovascular in nature, and that includes thrombotic events and bleeding events, and then the other half were other things, consequences of being in hospital, sepsis, pneumonia, that type of stuff. So I think, this is to me one of the important messages from this area. It's not talked about that much, but I actually think it's quite important because when you're counseling a patient about anticoagulation, this is really should be part of that discussion, I think, about the serious complications that can arise after somebody has a bleed. And therefore, brings back to the first point, which is that prevention is, really important. And then in these studies, of course, some patients restarted anticoagulants. In REVERSE AD, you can see about 3/4 of the bleeding patients restarted. We don't know what they restarted, whether or not it was low dose or full dose or antiplatelet therapy, we don't know, or parenteral, we don't know. Same thing with ANNEXA-4, you can see that 2/3 had started any anticoagulant, but only 1/3 started an oral anticoagulant. Again, we don't know the doses here. So this remains to be seen and is a controversial topic and something that I'm studying. So, in Canada, I've told you, we don't have Andexanet. We don't know when it's going to arrive. So what do we do in the meantime? Well, I'm sure you guys have all seen this. We give PCC, 4-factor PCC. This has become really commonplace. And it's almost as though it's been adopted as a standard of care treatment. We don't really have the data to support its use as a standard of care treatment, but it is reasonable to administer in a patient who's, bleeding to death in front of you or at, at serious risk of high degree of morbidity. And really what PCC is a concentrate of coagulation factors 2, 7, 9, and 10. Those are the vitamin K dependent coagulation factors. And really, it's used ostensibly to overcome the anticoagulant effect of DOACs by supplying those coagulation factors. Like we talked about factor Xa inhibitors, well, it has factor 10 in it, and thrombin, it has factor 2 in it. So we don't know really what doses. Some studies have used a fixed dose of 2,000 units. I know in Ottawa here, and that's what we did in Hamilton. In Ottawa at 50 units per kilogram dose that they use with no cap. So, there are some differences. And again, we don't have high quality data to inform which strategy is better. But I wanted to mention that, the evidence that we have that PCC actually reverses the anticoagulant effect of factor Xa inhibitors is really limited. We have in vitro studies and animal models and human volunteers, and then there's some small cohorts of patients without control groups that have informed at least some of the dosing that we have, that have summarized our experience, which is still valuable, but it's not, again, there's a lot of uncertainty about incremental benefit and harm. And so what we do find is that the evidence of reversal is conflicting and modest. And I summarize with this slide, which is a review article that one of the fantastic thrombosis fellows did, just summarizing all of the data about the different agents, and he went through all of the studies, lab studies, volunteer studies, and you can see that the results of the results of quote reversal really depended and varied quite a bit. So blue means complete correction, and light blue means some correction, and red means no correction. And he included some additional tests here like ROTEM or TEG and thrombin generation. And I think that those studies may provide us with additional information about the global hemostasis that's happening in these patients before and after PCC use. So it is still an area of uncertainty. And so these are 3 studies that have looked at PCC or activated PCC in the Shaw case for factor Xa inhibitor bleeding patients. And these were cohort studies. The patients were prospectively enrolled, but their charts were reviewed to look for outcomes. And these were all institutional protocols. So really, this is part of routine clinical practice. And the treatments there you can see were 4-factor PCC, 2,000 units, in the Majid and Shulman studies, and activated PCC, which is FEBA, and that's this. I'm not sure if people are familiar with activated PCC. It's very similar to 4-factor PCC, except that it contains some, the coagulation factors are like activated in some sort of proprietary way. But this is a treatment that historically has been given for hemophilia patients with inhibitors. So it's not something that's really widely available outside of treatment centers that treat hemophilia patients. And you can see that, here we see hemostasis, which was, adjudicated by folks reviewing charts using definitions that were established by the ISTH, and that, hemostasis was pretty good here, like, 70%, 80% of patients achieved hemostasis. We also see that these patients were documented to have thromboembolic events, and they range here, from 4 to 8%. And I want to caution you just a little bit about the thrombotic event rates. Of course, in the Majid study, wow, that looks pretty low, except that look at the rate of death here. So unfortunately, in this cohort, a third of patients died, and that may be why the thrombotic event rate here looks so low. Because patients, didn't live in order to have thromboembolic events, and these obviously were crude numbers and not, taking competing risks into account. So again, we're seeing, rates around 8% here in these studies, and look at the proportion of patients who died. 14 to 30% of patients in these cohorts died. So I just think, to me, this always, I look at these data a lot, and I think, wow, hemostasis is good, yet like a third of people are, 10% of people are dying. Something just doesn't add up there. Either we're not capturing hemostasis in a reliable way, or potentially reversal isn't really saving lives here. I'm not sure, and I think the jury is still out on whether or not there is incremental benefit and harm, and that's because of uncertainty about the data. But I think that's sort of profound. I'm not sure that hemostatic efficacy outcomes are meaningful if still 10% of people are dying. But in any case, and it's possible that, and likely that, those deaths are related to the patients who are elderly and highly comorbid and now are sick in hospital, and that sort of sets into motion a series of events that leads to death ultimately. But I think, again, doing a better job seems to be something that we should strive for to improve outcomes. But we really, these studies have no comparator group, so we don't really know about the incremental benefits of these drugs or the incremental harms of these drugs, including mortality. So this is from a guidance document that we did. I helped that I was part of for the American College of Cardiology. We had a guidance document about management of anticoagulant-related bleeding. It's actually really thoughtful. It's not guidelines. It's sort of practical guidance about how to consider these things. And so I'll leave this here, and I'm happy to share these slides with folks afterwards if they're interested in this reference. But this is, generally what is considered, an approach to management if reversal is indicated. For patients on dabigatran, we're going to be giving Idarucizumab. For patients on a factor Xa inhibitor, here we recommended andexanet alpha. It's available. If it's not available, then 4-factor PCC. But again, there's kind of regional variations in how that's implemented in clinical practice. This is another guidance document that I like from the Anticoagulation Forum, which is, really says the same thing. In the event that a patient has life-threatening bleeding, and we expect that the patient has relevant, clinically relevant DOAC levels, then reversal is indicated. And really, it's the same strategy as we had suggested in the ACC document. So if we go back to our case, this patient had life-threatening bleeding. It was ongoing, and we expected him to have a long delay in hemostasis because of his acute kidney injury. And so this patient, managed appropriately, acutely in the emergency department, was also administered 4-factor PCC, 2,000 units. This would have been at MAC here. It would be 50 units per kilogram as per protocol. And so I wanted to take this opportunity to just highlight the fact that gastrointestinal bleeding is not benign. And we do hear this a lot, that particularly patients with a gastrointestinal bleeding, we should be able to save them. We have blood, and we have, vasopressors and things that we can, we have endoscopy and procedures that we can do. But in fact, in these cohorts of patients, and this is this table shows just the GI bleeding cohorts from REVERSE AD and ANNEXA-4. You can see that again, most people did well. They achieved hemostasis, good or excellent hemostasis. Within 12 hours or 24 hours. And again, in these cohorts, short-term mortality at 30 days was 11%. And, in the REVERSE AD, they went out to 90 days, 15% of patients died within 90 days. So again, I think, these patients aren't necessarily bleeding to death from the GI tract, but it does mean that these bleed events need to be taken seriously. And I think, having a better understanding of what that means for patients is actually really important. So what do we do after bleeding? So the person has had bleeding, and hopefully they've done well. The hemostasis is achieved. They're ready to go home from hospital. What do we do? We get called about this all the time. So it actually became my area of research and clinical interest because we just get asked this every single time we're on call. And they're really, you think, well, I don't know when we should restart. So I started to, do some research in this area to see if we could, generate an evidence base for some of these decisions, which are actually really tricky. So there are no randomized trials. Most of the evidence that we have is from warfarin-related bleeds. And we know that this is a problem because anticoagulants are actually discontinued in a lot of patients, up to 50% of people after GI bleeding. And you would think that that was not the case, but if you review the literature, it is. And after ICH, up to 3/4 of patients never restart anticoagulants. So and I've just finished telling you about how bleeding is so terrible, and this, maybe why. But the other side of the coin is obviously thrombotic risk and what the outcomes are after thromboses. And with atrial fibrillation, for example, it's stroke when 80% of people have death or disability after atrial fibrillation stroke. So that's actually really important. So the clinical conundrum that physicians face is whether, when, and how to restart anticoagulants. We don't really know how to do that very well. We don't have evidence base. So I wanted to just let you know kind of what I'm up to here, which is that I started this program of research called PANTHER, post-bleed management and antithrombotic therapy. And it started, I always, as I started on faculty, some meta-analysis we did, which was published. We did an administrative database with ICS, which was just published in CMAJ in March. And we did a physician values and preferences study, which was really interesting also, which we published. And so now, carrying on to this later part of the figure here, to study patient values and preferences related to this decision making, and really in an effort to understand, how these decisions are made. Because of course it's tricky, and particularly in the absence of evidence, it's, we're not sure what to do. And obviously, these are both bleeding and thrombosis can have terrible outcomes. So it's helpful to pursue this kind of work, although it has been challenging, but also very rewarding. So if you look at all of the data that we have so far, you can see that this is a meta-analysis which we did of the studies that are 12 studies, which are observational studies in this area, restarting anticoagulation after GI bleeding here. So I'm just focusing on GI bleeding. And you can see that, this is fairly consistent across studies. In patients who resume anticoagulants after GI bleeding, the risk of recurrent bleeding is about twofold higher, and there's lower risk of mortality, and there's lower risk of thrombosis. And so the mortality outcome here is uncertain, particularly because these are observational studies. And so there's really a high likelihood that there was baseline confounding that contributed to some of these findings. But if you look at all of the studies and even studies that have been published since this one, really we're seeing, yes, anticoagulants increase the risk of GI bleeding and reduce the risk of thrombosis, which I think, makes empiric sense. So we then looked at a cohort of Ontarians. This is about 7,000 people who were admitted to hospital in Ontario with anticoagulant-related bleeding, and we looked at outcomes after them. We're still in the process of analyzing some of these data, so I hope that we're going to have some interesting findings coming up as well. And you can see that, these patients were patients mostly with atrial fibrillation, so relevant. And again, majority of patients had GI bleeding, which we predicted. But the other thing that we found in this, which, these patients were quite elderly, 83 or 81 was the average age here. So just about a quarter of them had dementia, many of them had other cardiovascular risk factors. And they were, these groups were fairly similar with respect to some of the other characteristics which we would be interested in. And so again, we found that in individuals who resumed anticoagulants versus those who did not, there was a twofold increased rate of bleeding, a reduced rate of thrombosis, and a reduced rate of mortality. Again, there's issues around baseline confounding, but it does kind of give us a sense that these findings, at least they're consistent across studies. I'm just going to put this up briefly. We did a mixed method study of physician values and preferences after anticoagulant-related bleeding. So we did focus group discussions and then this kind of cool survey methodology called discrete choice experiments. And really what this did was help us identify the factors that are important for decision making, and we were able to sort of rank them using utilities and identify, preference grouping. So the largest preference grouping actually, it was reflected here, where rebleeding risk you can see and thrombosis risk are really, neck and neck with respect to importance. Rebleeding risk was slightly higher. This was a 250 people answered this survey internationally, and it was a mix of internists and hematologists and cardiologists and neurologists. So. You can see some of the other characteristics that contributed to the decision making were, how severe was the bleed, what they needed the anticoagulant for, and some other patient characteristics. So we looked at kind of frailty or function here. But just to give us a sense that, physicians generally feel a certain way about restarting, and there's a lot of concern about bleeding in the post-bleed setting, obviously. And so the next step is to do a mixed method study of patient values and preferences. And I just got CIHR funding to do this work. So we'll see, how patients and physicians differ with respect to this. And we know from, AFib data and anticoagulant choice, qualitative work that patients and physicians, do feel differently about bleeding and thrombosis. And so in the absence of data, what do we do? And so this is like my job. So this is sort of what keeps the lights on. What do we do? Approach to restarting anticoagulants after bleeding. And I think the message I wanted to convey here is that really one size does not fit all. And so often we get asked, there are so many different permutations of scenarios that at the end of the day, this is really an individualized decision. To some degree. I think it's very helpful to understand or have sort of a framework to work from where we know what the risks are of rebleeding and we know what the risks are of thrombosis, and that does actually help a lot. We developed as part of that ACC management guidance document there's an app where it can walk you through some of the concepts around restarting anticoagulants, and I think they're very practical. But it starts with has the bleeding stopped? Well, that's really important. You can't anticoagulate a bleeding patient, which is like the #1 rule of thrombosis. So that's really important. And then, is there an ongoing indication for anticoagulation? Obviously, that's something, and we find that in our practice, sometimes we stop anticoagulants. So, and then really you are looking at both thrombotic risk and bleeding risk, and these are very different. So thrombotic risk would depend on not just the absolute risk of the event happening, but what the event is. what type of event it is. So, for us, a DVT is, a different than an ischemic stroke. And so it's just important to have a perspective on that. Same thing with bleeding. Intracranial bleeding is different than gastrointestinal bleeding. Even among those bleeds, not all intracranial bleeding is the same, and not all GI bleeding is the same. And I can tell you, from seeing a lot of these patients, that patients potentially feel very strongly like, sure, they have a GI bleed and they have to have endoscopy and be admitted to hospital and have transfusion once. Then when they're readmitted for a second time, it's much more tricky. And I can tell you that they really don't want to have a third episode and have to undergo endoscopy again. And so, that may change over time. So these discussions, it's good to keep them open, but particularly if they're old or frail and elderly, like, colonoscopy is no mean feat, even for young people. So it's just helpful to understand their context and to, pursue this in a way where we understand that their decisions may be different than ours, and that might change over time. And then of course, once you're resuming anticoagulation, we're, repeating all that other good motherhood stuff, baseline labs and reviewing co-medications, and really just to try to identify like the reversible things that can be addressed after to improve the safety going forward. And then follow-up is really important. So, who's going to be following these patients and what are we going to be following them for? So this is the last slide, and I think we have some time for questions. So I'll just leave these up. Really, I hope that, I've convinced you that that reversal is just one part of bleed management, and that, really prevention is the first step, and that protocols are extremely valuable for acute bleeding. Reversal is really for severe bleeds, and then hemostatic therapies can also be given but may not reverse. And then finally, that anticoagulants need to be reassessed after bleeding, even if there isn't a decision, that's something that can be reassessed over time. So I'll stop there, and there's the dawn wall from the base. So thanks so much for your attention.
Thank you so much, Deborah. That was great. I have a couple questions. One, could you talk about cost of the reversal agents?
Sure. So Idarucizumab last time, that's the one for dabigatran. Last time I checked, it was kind of priced on par with PCC. So it's about, I think, 3,500 Canadian dollars. Andexanet alpha is much more expensive, again, not approved in Canada. So for the high dose of Andexanet alpha, it's around, I want to say 40,000 US, and for the low dose is around 28,000 US. So this is something that comes up a lot when I've done these talks for American audiences, that sort of, how can we, use this judiciously? There is quite a move to use PCC in lieu of that. PCC is about $1 a unit. So if you're going to give, 2,000 units, it's about $2,000.
And is there a role for repeat dosing of the Octaplex or the PCC if there's ongoing bleeding? Like, how long do those factors, what's the half-life of the factors, I guess? Yeah, so they're different. It's
all the factors in there have different half-lives. The shortest half-life is factor 7, so it's about 6 hours that it's gone. The factor 2 or thrombin is the longest one. So I think there is potentially a role for redosing. I haven't done that personally, to be honest with you. I think that's where we kind of debate, like, should you give a lowered fixed dose, like 2,000 units, or should you give a 50 unit per kilogram big dose? And I guess I had always figured that's what we did at MAC, and so I'm used to doing that. But that there is an opportunity to give another dose if you need to, as opposed to giving a huge dose up front. But there is debate about that. Nobody really knows. And then other people would argue, well, why don't we just, like, person's dying, we should just give them like big dose, why fiddle around with a small dose? And again, we don't really know, how well they work. So I think it's really tricky.
I think Dr. Burney has a question.
Sure.
Yeah, first comment, Deborah, that was really an outstanding presentation. And don't tell Phil Wells, but that's the first time I've managed to stay awake through a DOAC talk from a hematologist in the history of my life. That was so
amazing.
Yes. I was very struck by the 10% mortality at 30 days, but is that really the DOACs that's the problem there in the reversal? Or if you took a propensity matched group of patients who weren't on DOAC and had similarly extremely severe bleeding, what would their 30-day mortality be? Must be, pretty high as well.
Yeah, so for warfarin, the warfarin data is similar. So we know that there's like this secret that there is this kind of mortality rate that's quite high, all-cause mortality. So people don't bleed to death necessarily. I think that's kind of the key. So when you hear a lot of these numbers, I think we've historically talked about fatal bleeding, which is different, right? The mortality rates are higher. I don't have the numbers off the top of my head, are higher for people who are anticoagulated compared to people who are not anticoagulated. They're not that different between DOACs and warfarin. But again, those are, so the people who are anticoagulated are older, sicker, more comorbid, like they have these underlying conditions that you're right would predispose them to, to dying after a bleed. So you sort of wonder, the bleed itself is, and I do, you do wonder this, where the bleed is sort of triggering a series of events that ultimately ends up in the person dying, right? So that's why I do feel that I'm not sure reversal is the end of the story. I think that there's more we can do upfront, working on, optimizing our antithrombotic therapies and preventing bleeds from happening in the first place. Yeah. I don't know. I can't tell you. I would like to tell you that I think that reversal agents will save lives. Presumably it does save some people's lives, or, particularly if a person has a, intracranial hemorrhage and you limit the size of the hematoma, I think that's really important because that's a morbidity issue for sure. But I'm not sure because we don't have those studies. That's why I'm so anxious for the randomized trial to see, randomized data. Yeah.
Yep, of course.
So I have another question, a couple actually. So, we're very good at making people bleed in cardiology. So we like to give people, antiplatelets on top of the DOACs, sometimes two. So it's a little bit out of the scope of what you talked about today, but, is there a role then for giving platelets to these patients? Because, we've, inhibited a lot of their platelet activity.
That's a really good question. There was a clinical trial where they evaluated platelet transfusion for people with antiplatelet associated bleeding, and there was higher mortality in the people who got the platelets. So we don't routinely do that, but your point is well taken. If the platelets are, if they're on aspirin, they're permanently, inhibited. So giving more platelets kind of empirically makes sense, but we don't routinely do that. And then that INCH trial came out with intracranial hemorrhage, so it made us even less likely to do that. I think if you, give a little bit of platelets, and you have so many millions of platelets circulating that I'm not sure that it does help. But I don't know about things like tranexamic acid or maybe DDAVP. Those things are not very well studied either. So it's a really good question. And again, I think part of that, at least in our practice, we see people all the time who are on these combinations of therapy. And I think if there's a rationale for doing that, awesome. But it's just helpful to make sure that that's reassessed. Do we still need to have 3 antithrombotics? Does that make sense? Maybe it does, and that's okay. But I think it just needs to be reassessed. And often we see complications when these things, maybe they aren't always reassessed, or patients' impressions are that they're just going to continue on these drugs in this way, indefinitely, right? So I think that's helpful.
Yeah, I've certainly seen the nephrology folks give the DDAVP.
Yeah.
Whether or not that's evidence guided or not, I don't think so. But I've certainly seen them.
Yeah, and you'd be worried about DDAVP. Also, there's cautions in people who have cardiovascular disease, so it's tricky, right? Like all of these things, it's tricky.
Yeah. One more comment from the audience is, if we're using these drugs for stroke prevention in the AFib population, then should we then be considering appendage closure and completely abandoning the DOACs or vitamin K?
Yeah, I know here in Ottawa, there's quite a good access to PFO closures. We didn't do that much of it at MAC, but I know this is something that people are looking at more and more. I think that it is a compelling idea, right? I'm not aware of data in the bleeding population particularly, but certainly patients for whom it's felt that anticoagulation isn't appropriate get referred all the time for these types of closures, and there's, I guess, maybe shorter term complications, but then potential long-term benefits from it. So I think that's actually a way forward. I guess there's going to be some data coming out about surgical LA closure this weekend. So we'll see, more literature on the patients for whom that would be appropriate.
Oh, I think we'll leave the last question to Dr. Burney.
Yeah, can you tell us why there's such a delay in getting Andexanet alpha into Canada?
I can't. I don't know. I think that right now they had focused on, I'm not really in the loop about that part of it. And I think that they were focusing on Europe, and maybe that Canada was, I don't know. I mean, it's a smaller market. I'm not sure. I think it would be a really challenging drug to have in our formularies from a healthcare, from a societal perspective, because it is so expensive. And we do have some expensive other drugs, right? But they're used rarely. And so this would, if it came to Canada, there would have to be, again, protocols around use and judicious use and stuff. I don't know. It's a good question. I know people are anxiously awaiting. I just, if we had better data about PCC, that would also be helpful, Yeah.
Well, that's excellent. Thank you so much, Dr. Siegal, for your presentation today. Very applicable to the drugs that we use on a daily basis. So thank you everyone for joining rounds this morning. I'd like to remind you that next week's rounds are by Dr. Kevin Bosar, one of our cardiology residents. He'll be presenting on the role of inflammation in cardiovascular disease. So thank you again to today's presenter. Have a good day, and we'll see everyone next week.
Thank you.
Thank you.
Bye.